My name is Alan Pestronk. I'm a neuromuscular specialist. I work at Washington University in St. Louis. We've been thinking about and trying to understand, diagnose, and treat inclusion body myositis for a long time. We've only been, what I'd say is that every year we get a little smarter. The ways that we're smarter than we were 10 years ago are, first of all, that we understand more about how the disease presents. It's always been pretty easy to make a diagnosis on physical examination. We examine patients and walk into the room and you shake my hand and you can't flex your fingers here. And that makes it likely that you have inclusion body myositis, or at least that raises the possibility. Then we examine you, and the other group of muscles that's weak beside the muscles here are the muscles that hold your knees straight. And that's interesting to me because I can use it to make the diagnosis, but it's terrible for you because when you bend your knee, you can't catch yourself, and down you go. And so that gives patients with IBM a particularly hard time. We do physical therapy for that, particularly bracing. There's no exercise that helps that. Actually, I might take an aside here. There was a lot of back and forth this morning about exercise in IBM. My opinion is that it's very clear from every neuromuscular disease that's been tested so far that mild degrees of exercise done regularly are a little bit good for you. They don't fix your disease in terms of changing the underlying muscle damage at all. And again, unless you're trying to be a marathon runner, you shouldn't worry about hurting your muscles with exercise. The main thing you should worry about hurting yourself with exercise is not falling and breaking something. Because the worst thing you could do is be completely inactive. When you're bedbound with IBM, when you get up out of bed again, you're much worse than you were before, and you're lucky to get back where you were. So the little bit of regular exercise is a really good rule in all of neuromuscular disease. One day we'll have controlled trials of that in IBM, but I think as a clinician that's a good rule. In terms of, go back to the main point. What's changed in 10 years about the diagnosis is that Steve Greenberg and the Italian group have identified that 75% of patients with IBM have an antibody that's against a protein with a long name. We abbreviate it anti-5C1A. That's clinically available. We measure it in our laboratory. If you have any doubts, this can help a little bit to confirm the diagnosis, although it's not perfect. It's not always positive in patients with IBM, and it's not always negative in other disorders, but it can help you and your doctors make a decision that you probably have that disease. And up until 3 years ago, we didn't have any kind of blood test to help. So that was something that we started doing in our lab just because we thought it would be helpful to people. And then the other thing that's become helpful is that we are developing, and other people are developing, better ways of looking at muscle biopsies to try to decide whether somebody has a treatable itis or myositis in compared to an IBM where drugs are mainly going to cause side effects and aren't going to help you much. And so when we look at the muscle biopsy now, instead of just looking for the vacuoles that everybody talks about, it turns out that in this disease, muscle fibers have abnormal mitochondria, which are the little things inside muscle fibers that make energy, and they have clustered proteins inside muscle fibers. And when we look for all three, the statistic is that if you just look for vacuoles, then you can only make the diagnosis on a muscle biopsy in 50% of cases. But if you look for the vacuoles and the clustered proteins and the mitochondrial disease, the accuracy of the muscle biopsy goes up to 90 to 95%. So the muscle biopsy is much more useful, and that makes it critical, in fact, that when anybody has a biopsy, the biopsy is analyzed to its fullest extent, so that you can decide, A, if you have inflammation, whether it's a treatable disease or it's a more difficult to treat disease like inclusion body myositis, or on the other hand, if you have inclusion bodies, whether it's IBM or it's a hereditary disease, we can come close to guessing which of those two situations is the case as well. So that's right. So you figured out that my next sentence is, I gave you all the information I'm going to give you to start with, and I'm here to answer your questions, and you raised your hand first, so go.
Sounds good. For everyone, if you could just wait a few seconds when you ask a question, I'll come over to you, and that way everybody can hear.
I've had two biopsies, one in 2013 and one recently as May of this year, and or June. And the reading of the or the diagnosis of the biopsy, you're talking about the broad range that they need to look at. When did that become? Would that be a practice in most labs throughout the country? Or?
Some labs do it, some labs don't.
So.
And you'd have to identify the lab, and your doctor would have to talk to you about, again, what the testing on the muscle showed.
So my doctor is not, my symptoms are a little bit different than IBM. However, the biopsy said most likely it's IBM, but there's other possibilities. So she hasn't put the label on me yet, and I'm just curious about who's, if it's somebody like reads an X-ray, or they read, now there's new technology, or there's new terms, or there's new considerations, and I understand now, but it depends on the lab. I had one down at the University of Florida, and the other was down at Mayo. So.
Okay, so Mayo doesn't do all the tests, for sure.
Right.
I don't know where the other one was done where.
Well, University of Florida pathology did the.
Right, but so Mayo only does a few of the tests, and not all of them, so they don't get all the information they could. And I mean, again, it's a matter of if your doctor isn't sure, the frozen muscle can be sent to another lab, and all the other tests can be done. So it's just a matter of again, it's a critical issue with you're on a scooter, you're having trouble getting around. You need to know whether to be aggressive and try to figure out further what's wrong with you and how to treat you in terms of giving you more medicines, or to say, modulating agents don't work, and then what you need to do is help you in other ways.
Other questions?
Yes?
Do you have to have a new biopsy for that to have further studies done?
No.
Or can it be done from slides that were done in late 2008?
So you can't do it from slides, but many laboratories save a piece of the frozen muscle in the freezer, and we have every muscle ever done since 1980, so we can do that. A lot of labs just save the muscle. They can revisit it, or somebody can send it to a lab that does more sophisticated testing.
Where could you have it sent?
Well, send it to me, to our lab at WashU. We do all that testing, and it's part of my research to try to understand all the ways that the muscle biopsy can be analyzed to be specific for one diagnosis or another.
Okay, thank you.
You mentioned blood tests. Could you tell me what that entails? What kind of blood tests?
If you've had your blood drawn, your lab draws your blood and sends it. I think we're the only people in the United States that do it.
What do you look for in there?
So it's an antibody, so a protein floating around the blood that binds to a particular protein called NT5C1A. And what we do is we take your blood and we put it on a piece of paper with a bunch of proteins on it. And if it binds to the one right protein, then we say you have that antibody.
That's for IBM.
That's for IBM.
I'm about to have another biopsy. For 5 years I've been poly, but everybody says you have the symptoms of IBM. So, and when I went up to see a neurologist in Jacksonville, and he said that he did some testing about 3 hours, and he said, you have symptoms of both. He said, I can't tell you what it is, so we're having another biopsy done. But if you say that we can use the old slides and do it from that?
Well, if there's an old biopsy, it's the first thing. If somebody has your muscle sitting in their freezer, I wouldn't do another biopsy first. What I would do is to take the old biopsy and reanalyze it. Never like to do any invasive test more than once if you can look for subtleties. And again, the parallel thing to do is to have your blood drawn and see if you have NT5C1A antibodies.
Okay.
And what all that allows us to do is to allow us to practice both the art and the science of medicine. As you know, as you've said by now, doctors will never give you a 100% guarantee on anything. It sounds like you didn't even get a 50% guarantee.
No, my biopsy when the doctor got it, it had handwritten all over. It could be poly, looks like it's poly, but you know, just
so
3 or 4 statements on there.
Right. My rule is if somebody calls something polymyositis, probably the pathologist wasn't great, and then you should reanalyze it somewhere else.
Right. Well, I just realized that.
I think you need we all need a way of and we all read people's body language and words and stuff, and I read biopsy reports like that, and I try to understand whether the pathologist reading what he saw through the microscope is somebody who really understands all the subtleties of disease, because in a lot of places, one of the reasons for mistakes in this field is that the pathologist is somebody whose interest is in brain tumors or something, and they do a little bit of muscle biopsy evaluation, but as in everything, if you have somebody who does a lot of one thing, they get good at it.
This took about a month to go back because they kept saying they're sending it to somebody else. So I don't know, they passed it around, I guess.
So I would, before I had a second biopsy, I would make sure that somebody who's a real expert in inflammatory myopathy and IBM pathology looks at it carefully, makes sure that all the stains were done on the first one that could help make the diagnosis before I would do a second invasive test.
Okay, where do we send that to? Did you get
What?
if we do get the slides?
Well, it's not it's not the slides. You need the actual frozen piece of muscle. We can look at slides too. There are certain neuromuscular pathology labs that give second opinions about about what you just seen through the slides. Again, I hate to keep saying I can do it, but we do it. Mayo does it. Dr. Mozaffar's group can do it at UC Irvine. What you need to do is just whoever your doctor uses as sort of a specialist that they refer people to when they're not quite sure is where you go, or as a default position somebody can send us biopsy slides and we can read them. But if the biopsy slides are equivocal and you're not sure, the next thing to do, as I said, is to get the frozen piece of muscle and do, there are 4 or 5 other kinds of things we can look at in the muscle to try to guess whether you have an inclusion body myositis.
Earlier you said Mayo did not do the whole string of tests.
That's right, Mayo doesn't do the lot. What?
But they pick up what they need to on Mayo's if you brought it.
Well, I mean, the people at Mayo are very sophisticated at muscle disease, and they're very good at seeing what they can see. But if you don't do the special stage and other things, then you're not always sure.
One question again related to this. In January of this year, I had a muscle biopsy at the University of Colorado Health Sciences Center. And it was taken from the left quad. I don't know if ask me here, Alice, which one it was exactly, but it was real fatty and very difficult to determine, and they couldn't see any inclusion bodies at all. And so they, based on more symptomology, the neurologist calls it IBM. And I'm wondering, could that piece of tissue still, could you analyze that, and would a blood sample go with that?
Well, the blood sample, the second question first, the blood sample is independent.
Right, I realize that, but would that be something that should go with tissue to your lab, or?
No, the blood test would go separate. Do you mean it's a separate test that draw blood and send that?
Right, but I mean, it could be done.
The muscle tissue could go there. I mean, again, if they did a biopsy and there were no muscle fibers there, it was all fat, then that muscle is badly enough damaged that it's unlikely that anybody's going to be able to use it to make a diagnosis.
So then, what would you recommend for being more positive about what it is? I mean, they said, well, we could do a muscle biopsy in your arm and go from there, but he said, I'm pretty sure this is what you got. And I'd like to know a little more positively what would be.
Then the blood test, and you may end up needing to have another muscle biopsy.
So
Less affected muscle. So what we do to try not to get to the conundrum that you have, where I don't want another muscle biopsy, is to do imaging of the leg or the arm, either with an MRI or with ultrasound. And by doing those tests, we can see where there's enough normal muscle to do another muscle biopsy. An in-between option, again, it's not a good option, but it's a solution if you really don't want another open muscle biopsy, is that we sometimes will do something called a needle biopsy. We don't get as much tissue as the other, but it's much less involved and traumatic, and so that's a possibility. Although, I think in the end, if you really want to know, and the first biopsy didn't show anything, you may end up needing to have another muscle biopsy.
And would that be where I had it, or would I need to come to?
I think that if that Dr. Ringgold and the people at Colorado are really good doctors, and
I mean, I believe that.
you're in.
In other words, don't worry so much.
Right. No, I think that that's a good muscle place where they do reasonably good muscle biopsies, and actually every once in a while, if there's a test that they can't do, they'll end up sending me the piece of muscle and we'll do the extra testing. So one thing you could ask your doctor is if there's any muscle there at all, and they're not sure, if they want to send it to me for a second opinion and to do some more testing.
And at the same time, could we send blood? Would that be?
Yeah, anybody can send blood at any time. You can do that before.
And that would be definitive per se.
No, but it would increase increase the likelihood that that's what you'd have a lab test that would be positive to go along with the clinical impression that that's what you have. And each added piece of information adds to the certainty that the diagnosis is correct.
I'll ask Dr. Riegel, let's see if there's a key to help us out that way.
Say hello.
Yeah, I will. Okay, thank you.
Anyway, this is my wife May, and I'm concerned too, and we're getting this other doctor now after 4 or 5 years involved, where this specter of wrong diagnosis is coming to the forefront. If we get the doctor that we're now seeing, or going to see in Jacksonville, to get involved in getting this sample of blood and the biopsy sent to you for examination, would that be in line? No.
Sure. I mean, I don't, we see patients for second, third, fourth, and fifth opinions all the time. I mean, the blood test is just a blood test to go back to your doctor and they'll tell you whether it's positive or negative. And they can look at the literature and decide what that means in terms of the raising the likelihood or decreasing the likelihood of the diagnosis. And then again, we do consultations on muscle biopsy interpretation, if that's what you want.
Well, yeah, and what's involved here is this doctor that we're getting involved with because of this diagnosis, second-handed, whatever. His thrust is he doesn't trust her. There's handwritten notes on the biopsy report saying it could be, it might be, whatever. So if we go to him and ask him to send it to you to take a look at, would that be in line?
Of course. I mean,
Okay, and that would be to Dr. Alan Pestronk, where?
If you type in Alan Pestronk into Google, my website comes up and all of the contact information is there. I'm happy to use my card, but
No, we'll look it up.
okay. I'm all over the internet. I don't even know whether there's a picture of my wife there too.
Man.
What is the difference in that blood test and the DNA test for this?
So there is no DNA test for sporadic inclusion body myositis. The issue is that when you look at muscle biopsies, in inclusion body diseases, some muscle fibers have little holes in them. And then the list of problems that comes up that can cause that is on one hand hereditary disease, and on the other hand diseases like inclusion body myositis that come out of the blue. There are certain clues when the doctor just examines you which of those you have. For instance, if we talk about the quadriceps muscle, which is this guy, set of muscles, which is this guy right here. In IBM, this muscle gets weak early in inclusion body myositis, non-hereditary, whereas in the hereditary form of IBM, all the other muscles get weak and this one stays strong. So that helps me to start to make a guess. And even before that, I can talk to you and ask you whether you have anybody else in your family with this disease. If your disease started after the age of 50, then it's probably the sporadic disease, not the hereditary disease. But in any case, if I think it's the hereditary disease, then we do gene testing. If we think it's the sporadic disease, then we do the blood testing looking for the antibody and look at the biopsy, and if the biopsy shows inflammation, then it's likely to be the sporadic disease. If there's no inflammation, then maybe it's more likely to be the hereditary disease. So that's kind of the logic tree that we go down.
I was diagnosed in late 2008, and they said it was classical SIDM.
Okay.
And last year I went to the doctor, and he says, I think I'd like to get DNA testing. Because I'm not sure now if it's IBM anymore.
Okay.
Because my mother had something similar, which she thought was polymyositis. But who knows what she had.
Right. So I mean, again, the logic tree is always the same. You need somebody who's really good at looking at the muscle biopsies to tell you whether it's classic inclusion body myositis or hereditary IBM, and then you can decide whether to do additional testing. It sounds like your doctor's not quite sure, and it now turns out that the company there's a company that's testing to see whether there are drugs available that might help the hereditary form. And so what they've done is they've made free gene testing available to everybody. And so it's likely that your doctor read an article or saw something on the internet about this free gene testing. And I'm watching you, in fact, how you're holding the microphone. And you're not holding the microphone exactly like a patient with IBM would hold the microphone like this. And so I'm wondering, I'm sitting here, wondering in my head whether you have IBM or not, SIBM. And so that may be what your doctor was thinking about as well. Since, you know, it's like free food, free gene testing every doctor wants to do.
What is the name of that company? Because he's not made anything very clear to me, and I refused it on my last visit because I felt I didn't know enough about it. What's he going to do with this?
It's just it's a simple blood test. It provides no, the company that pays for it is called Ultragenics. ULTRAGENYX. And YX. And it provides no genetic information other than whether or not you have mutations related to to one form of hereditary inclusion body myopathy. There are actually several.
So it's the only information he's looking for is if you have hereditary IBM.
That's right. That's specifically, I mean, again, I don't know what's in his head, but that's my guess.
I don't know what's in his head either. It's not going to make.
We're both trying to read the tea leaves.
Yeah, so ULTRAGENYX.
ULTRAGENYX.
Okay, so I'll do my research online.
And then the gene testing, the gene is called GNE. That's the gene that they would analyze and look for mistakes in the gene code. GNE, not GNE. GNE.
And you think, like, I'm from Canada, so he has access to that separately.
Well, he had, yeah. I mean, I think that the gene testing is available in Canada.
Okay.
And people send us the blood test as well from Canada all the time.
All right, thank you.
For anyone that, excuse me, that I have not met, I'm Chris Goder, and I actually have a very rare form of hereditary IBM myself. It is not the GNE gene version. It is I have a defect in my VCP gene, the villosum-containing protein gene. It's extremely rare, and I'm happy to talk offline to anybody that wants to know more about the hereditary forms. Yes, my father also has IBM.
So that's a disease that's transmitted dominantly, meaning it goes from one generation to the next generation to the next generation. It causes a pattern of muscle disease that can be very patchy, but doesn't look like the sporadic pattern. And it can also cause problems in your brain and problems in your bone in different people. We've been very involved in studying that too.
Yes, so Dr. Pestronk is very much a knowledgeable person in my particular form of the disease. The full name of my disease is inclusion body myopathy with Paget bone disease and frontal temporal dementia. And as Dr. Pestronk mentioned, there are those three aspects to it, and you can have one, two, or all three. This is more detailed than really anybody needs to know. But me, myself, I am, and my father, we are only exhibiting the myopathy aspect of the disease. So I do not have dementia, yay, and I have very, very strong bones, so I do not have the bone part either. And again, I'm happy to talk separately to anybody about hereditary parts.
Hi. I don't know enough to know if I should ask for my biopsy to be sent somewhere else for a second opinion. I was sent to a big emergency at a Toronto hospital with a CK of 3700, but I was reacting at the time to an antibiotic called Cefprozil, while I was in the emerge, they ran ceftriaxone through me. Internal medicine came down and said, oh my God, that shouldn't have happened, and a rash developed between my knees, and they said that's a classic dry rash. Then rheumatology came down and said, oh no, you've got a 3700 CK, that's dermatomyositis. So it was kind of, which one is it? And then they did a muscle biopsy. The muscle biopsy took 7 weeks to come back. I don't know if that's common for it to take that length of time, but it doesn't. It took 7 weeks, and I started thinking, did they lose it? where is the muscle biopsy? And the doctor at the big trauma hospital kept saying, I don't even need it. It's dermatomyositis. I don't need it. It's dermatomyositis. So all those weeks he kept telling me that. Finally it came back and it said, it's dermatomyositis. And I don't know, I just questioned the whole thing, and I don't know if I should ask for it to be sent somewhere else.
Well, I mean, I think that what has to be done in a case like yours where you're not sure is first to go back to the doctor that originally examined you and ask exactly what the logic is behind putting the name to your disease. I mean, some findings on the muscle biopsy are nearly 100% specific for dermatomyositis-like syndrome. And so if those were found on the muscle biopsy, then you probably have a form of dermatomyositis.
I think he was going on the fact that I had the anti-Jo1 antibody.
Okay, well, so Jo1 disease is either polymyositis or dermatomyositis. The issues with Jo1 myositis are that is what we call a multi-system disease. Patients with Jo1 myopathy have muscle disease that causes weakness. If you look in the muscle, the gristle between the areas of muscle is more damaged than sometimes in the muscle itself. If you have a Jo1 antibody, you're at increased risk not only for having muscle disease, but also for having lung disease, because the same kind of connective tissue that's in the muscle and makes the meat tough is also in your lung, and the immune process reacts against your lung and causes scarring in your lung. It can also cause skin disease, and you get rough skin over the surfaces of your joints that it's described as a mechanic's hand, so you can imagine what that rash is like. And then you get arthritis. If you have Jo1 antibodies, then that's a very strong marker. That I don't call that dermatomyositis, I call that an anti-synthetase syndrome, where you have these antibodies and you can have skin disease, you can have muscle disease, you can have lung disease. And what your doctor has to pay attention to is you need to be screened for lung disease every once in a while, in addition to your muscle disease, to make sure the disease isn't affecting your lungs, and that can be disabling. So, but probably in your case, now you've told me you have Jo1 antibodies and arthritis. It's likely that you have a correct diagnosis. You know, again, I could look at your muscle and say, oh yes, there's this subtlety which makes it more likely, but given the fact that you have that antibody and some of the typical features, and again, we haven't discussed it, the other possibility is of whether your CK has stayed high and didn't come down. That would suggest that you have continuous muscle disease, and that you need to be followed by knowledgeable physicians and treated.
It came down on high doses of prednisone, 125 solriamfetol and 80 oral for weeks, and it brought the CK down to 34. We've introduced Imiran. I don't know with Imiran if we should have maybe chosen CellCept. There was a couple of different choices there. They hadn't seen any lung involvement, so at the time we went with Imiran.
So once a year, your pulmonary function should be evaluated in whatever way the doctor thinks is appropriate. It sounds like your doctor did, a number of the right things to confirm, because as for IBM, what you try to do in all forms of immune muscle disease is to confirm the diagnosis at 3 levels. We examine you, we look to see what the typical findings are and what that would be consistent with. Then we do a blood test and look for a blood marker, and then we do a biopsy. And if all those things line up, then you're 99% sure that you made the right diagnosis. And it sounds like that's where you're at.
Okay, so I probably don't need to have it sent anywhere else?
Probably not.
Okay.
Again, if you can ask your doctor whether she has any doubt about it, but if you have the antibodies and somebody said the biopsy is typical, and you had evidence of muscle disease with a high CK, you know, that sounds like you have at least 3 nails
Okay.
in the diagnosis.
Absolutely. We have more than enough time for everyone, so do not hesitate to ask.
I just wanted to ask, it seemed to me that someone on the dais yesterday said something about this was not a hereditary disease. Did anyone else hear that?
So again, it depends on exactly. Dr. Greenberg said something about words. The issue is that sporadic inclusion body myositis is not a hereditary disease. And so the process of making your particular diagnosis, whatever it is, involves the doctor thinking, is this a hereditary disease? Is this an inclusion body myositis? Is this a treatable inflammatory myopathy? And putting you in one of those categories. And then if I put you in the SIBM category, then I'd say you don't have a hereditary disease. If I put you in the hereditary category, then you do have a hereditary disease, and the implications for what happens to you and other people are very different. So people are mixing 2 things up, and that's why you were confused.
There's no medication for the HIV.
Well, so the idea is that there's a very interesting trial now being run by Ultragenics where they're giving medicine called sialic acid to patients with this form of HIVM, where it's thought that sialic acid is deficient. And they're hoping that they can help people. And the stage in which that clinical trial is now is that they've done a couple of small trials, and there's some very hopeful information there that suggests that the drug may actually be useful. So the answer is that it's possible in the next few years there will be a treatment for HIVM, whereas SIVM, a number of people are trying different things, but whether there's hope for that or not, I'm not sure. I think we'll see. Jared Mendel is trying myostatin inhibitors in Columbus, Ohio, and there are other people trying other things, and we'll see whether those work.
But doesn't the hereditary form come at a younger age?
Sometimes.
Or just sometimes?
Right. I mean, sometimes hereditary form can start relatively younger. Sometimes hereditary form can start in the 40s and 50s. Usually, if you have inclusion bodies in your muscle and inflammation in your muscle, and you're over 60 when the disease started, then that suggests it's not hereditary.
If you're curious, my father was diagnosed with HIV. Well, at the time we didn't know it was hereditary. He was diagnosed with IBM at age 44. I was diagnosed at age 38. I started noticing symptoms at age 30. I've also just retired from the U.S. Air Force, though, so my strenuous physical activities, I think, highlighted the disease at an earlier age.
Mine's confusing because I was in my late 60s when it started, and that was the clue that no, it's SIBM.
Right.
It's just this past year, the doctor's correcting the doctor's wrong.
Okay. And Dr. Pestronk, if I understand correctly, the sialic acid treatment would be particular just to the GNE form of HIV? Okay.
Sorry to hog the microphone, but 2 quick questions. One, if we get this biopsy sample and blood sample sent to you for examination? What's the financial involvement?
Like any time going to the doctor, you pay a copay and your insurance pays the rest, and it depends on how much, whether you're in or out of network and all the other stuff. Most of the time for the lab work, you know, there isn't a lot of financial stuff because insurance companies.
I mean, in your regard involved in it.
Well, will I make money if you get the biopsy?
In a word, yes.
No.
Another word, what do I pay? No.
No, so you don't pay, so, I don't know, I work for a salary. And so what ends up, my department charges for my services in some way or other, and your doctor can find out how much the particular test that we do will cost your insurance company and that kind of thing.
Okay, last but least, you're going to get a biopsy sample, and you say it's from a biopsy that was taken and frozen. This was 5 years ago. Would it still be available?
In my lab, every biopsy is available from 1980.
Okay.
So what I can't tell you how long other labs
Okay.
stay their stamp.
Fair enough. Thank you, sir.
So, okay.
Do they
We
know?
usually find a way.
Do they have a theory as to why the sialic acid treatment would help? Does it have to do with sialated Ig?
Well, so so the question is, in this one form of hereditary IBM, what happens is that an enzyme is mutated that puts sialic acids on proteins. And so the thought is that maybe if you made more sialic acid available, even the enzyme that doesn't work that well will work better because there's more sialic acid available, and put the sialic acids on the proteins, which will then function like they ought to function, and aren't functioning well in the disease, but might function better if your body can put more sialic acids on it. Does that answer your question?
Thank you.
Who else? Please do not leave the session today without feeling like your questions are answered. We still have lots of time.
I had the test for Joe 1 and I did not have it. So is that any indication of what it might be?
So the absence of an antibody doesn't help us much. Most patients with any kind of immune myopathies won't have antibodies.
Okay.
And so the absence of a particular antibody just tells us that we need to keep looking for a different one and see what we can find. Because the presence of a particular antibody labels your disease. I mean, it's like saying, I'm not going to tell you what my first name is, but it's not Robert. There's still lots of other names out there.
Okay.
Others?
A little comment.
Sure. Comments are good too.
My brother keeps asking me if he should be worried. We seem to have a wonky autoimmune gene in our family. My dad had arthritis, I've got rheumatoid, and myositis. My son had his colon removed at the age of 24 to ulcerative colitis. My other son has Crohn's, and my sister has lupus. And my brother keeps saying, should I be worried?
A little bit. It's a well-known phenomenon, and we don't know exactly what the genetic thing is, but if a member of your family has an autoimmune disease, then there's a somewhat increased risk that you're going to have autoimmune disease. And if 5 members of your family have autoimmune disease, it probably increased even a bit more. But it's not the kind of thing he should build his life around. If it happens, it happens. It's sort of at random. You know, even if it's a 50% chance, it's a 50% chance it won't happen.
And my son with the severe colitis also has Myositis disease, which I think is another autoimmune.
So you have it, your family has some kind of a genetic predisposition. We get smarter about that. The doctors this morning were in the panel were talking about, Dr. Reed and some others were talking about understanding about genetic predisposition for autoimmune disease. We don't know about a genetic predisposition for SIBM. There's no evidence that there's a genetic predisposition there. We've been doing studies where it turns out that some people with SIBM are misdiagnosed and really have his disease. And that turned out in the study where we studied 57, the genomes of 57 patients, the mistake was made in 2 patients where they'd been misdiagnosed by people in our hospital as having SIBM, when in fact they had HIBM with mutations in the VCP gene.
Well, then, is it possible to have a parent and a grandparent who had muscle weakness and he still not have HIBM?
There's a
Like a genetic component or something?
right. So that may be why your doctor, so that doctors have all these little odd sayings, and there's something called Hickham's dictum, which is a patient can have as many diseases as they damn well please. And the bottom line is that you should never make a complete assumption from, just because it's a hereditary disease in the family, it doesn't mean you absolutely have it. It makes it more likely that you would have a hereditary disease. And again, if it's your grandmother and your mother and you, then it may not be that maybe that the G&E disease is what you have, and somebody wants to look for the VCP disease instead, or look for both.
My son's take on it is that we all have the same thing, it just has different names.
I don't think that's right.
No?
I think that each of those diseases has a completely different set of treatments and implications as to disability and longevity and all that. It's a predisposition to have your body react against something in your own body, but it could be your ears, your eyes, or your liver, or your muscles, and everybody gets a different random hit.
I recall he had a carrier because his deceased wife had RA. Now his oldest daughter has RA. His son, a couple of years ago, came down with scleroderma internal, and his other daughter just lately came down with an RA or scleroderma first. I think it was changed to RA, and then I have it. But so here,
He's got the protective gene.
he's a carrier.
Right. Well, he's carrying you. But,
John, I don't know if anybody in my family that has any autoimmune disease.
So, but SIBM doesn't have that predisposition that Joe would have. Because we don't know what causes SIBM. We're still not smart enough there.
Along those lines, though,
Excuse me?
is there an age where it doesn't attack anymore?
For SIBM or rheumatoid arthritis?
No, for what you did.
And so with
IBM.
So with SIBM, the frequency of the disease goes up with age.
It goes up with age.
Goes up with age. So if you're under 45, it's very unlikely you have SIBM.
So I'm still not safe.
But you don't have any more. It's not contagious.
That's right.
So you don't have any greater risk than anybody else.
So I can live by Hickham's dictum.
You can live by Hickham's dictum.
Thank you, sir. You're great.
Hi, my husband was diagnosed with dermatomyositis about 3 years ago. He had all the symptoms of the muscles, muscle weakness, muscle fatigue, and you name it. He had it for many, many years. One doctor finally did a skin biopsy once he started showing the rash symptoms, and the skin biopsy came back 97% dermatomyositis. So then he did a muscle biopsy, and that came back positive dermatomyositis. So we have a definite diagnosis that I do feel comfortable with, but in 2002, he got West Nile virus encephalitis, really, really bad. They told us that a normal person could fight that infection or virus, and it's out of your system in 3 months. For him, for whatever reason, he couldn't fight it, and it wouldn't leave his system. He was part of a study, and they tested him for 2 years. It was still in him. And so from 2002 to about 2009, he suffered from muscle aches, fatigue, a lot of different symptoms. And in 2009 to 2012, he continued to get worse until they finally diagnosed him with dermatomyositis. To this day, he still has a lot of muscle aches, fatigue. He's no longer on prednisone, but he's still on Cellcept. And I'm just wondering, do you think there could be something else, or do you think it's just the dermatomyositis symptoms making him feel the way he does, and will he probably always feel that way?
So, actually, Hickham's dictum again. At least 2 diseases sound like it's there. It's when somebody, so the issue with West Nile virus, and I'm not sure how anybody decided, usually West Nile virus disease is what's called a monophasic disease, which means it comes, gets bad, or doesn't get bad, and then goes away. And occasionally, in a small percentage of people, the virus infects your nervous system and makes you weak. And so you get weak in one limb, usually a leg. And then if you're lucky, the damage to the nerves is partial and you get some recovery. It's very common when you get damage to nerves that after you recover, for one reason or another, you end up having some discomfort that's there, either because you have some residual weakness and you're using your body in funny ways. You try to walk like this all the time, you'll start to hurt. And people with those kinds of problems can have pain. Again, I'm not sure what the chronic pain is. It's possible that a little bit of the dermatomyositis was there before, and that was causing the pain. Not clear. And now it sounds like you're fairly convinced that there's dermatomyositis there, and that would cause weakness in the skin rash, and it could also cause some pain. And I can't quite dissect, if he's having discomfort now, whether it's related to the myositis or the previous West Nile that he was having pains with before he got the myositis. Is that?
Yes. The only other thing I forgot to mention is he does have a lot of nerve issues as well. But we think, because we haven't found any doctors that tell us anything different, we think it's because he has neck and spine issues as well. And they say there's no correlation between the nerve and the muscle issues, back and the neck and the dermato. He gets really severe back spasms, and they can't tell us whether it's because of the dermatomyositis muscle issues or the nerve issues. I mean,
usually many of the muscle symptoms get better if the dermatomyositis is adequately treated. And so maybe that's those kinds of problems or something else.
we haven't been able to find a good neurologist in our area. Do you think it would be wise to find a good neurologist to pursue the neck and back nerve issues, back spasm? He still gets back spasms to this day, but yet they're not, well, he's on Cellcept, but they're not treating him with any type of prednisone or any other medicines for the dermatomyositis.
So my rule is that if you're miserable, if a symptom is affecting your daily life and stopping you from doing things in one way or another, and that a diagnosis hasn't been made, that it's a reasonable thing to try to find somebody who can make a diagnosis. Because otherwise, the prognosis is you're going to go on being miserable.
Right. The problem that we have is a lot of doctors, when they hear all of the different problems that he has,
Get scared off.
yeah. One neurologist said, you you have too many large, complex complications, so I'm gonna focus on your carpal tunnel. Well, that's like the least of our worries, so.
Right.
We never went back to see him, but we have had a very hard time finding a neurologist. And we're willing to travel to find, to see a neurologist. We just, at this point, don't know.
Where do you live again?
In Mexico.
So you've been to UNM?
We have been to one neurologist in Albuquerque, but not to UNM.
So, I mean, there are a couple of good neuromuscular people at UNM and at academic medical centers. That's all we see are people with 3 or 4 different problems, and you just have to sort them all